Hi, my name is Fatima Romo, and I'm going to talk about primary hyperoxaluria. Definition. Primary hyperoxaluria is a rare inherent genetic condition present at birth. In this type, the liver doesn't create enough of certain proteins or enzyme that prevents overproduction of oxalate, or the enzyme doesn't work properly. Excess oxalate is eliminated through your kidneys in your urine. The extra oxalate can combine with calcium to create kidney stones and crystals, which can damage your kidney and cause them to stop working, causing that renal failure.
Calcium oxalate crystals, which look like calcium oxalate crystals, which look like grains of sand, come together to form kidney stones. These stones can inflict severe pain. Now imagine having to deal with recurrent kidney stones, which could be a sign of multiple genetic disorders that go undetected for years. One of these genetic conditions is called primary hyperoxaluria, or PH. Primary hyperoxaluria is a family of rare autosomal recessive disorders in which the liver overproduces oxalate, an end product of metabolism in humans that has no known benefit. Oxalate is normally excreted by the kidneys. Then what happens differently in people with PH? Well, the genetic mutations lead to certain enzyme deficiencies in the hepatocyte, causing overproduction of oxalate. There are three known types of PH: PH1, PH2, and PH3, which are caused by one of three different mutations. As a result, the breakdown of glyoxylate is disrupted. Glyoxylate then starts to build up in the cell's cytoplasm. Regardless of the pH type, excess glyoxylate is broken down into oxalate by the hepatic enzyme LDH. A therapy that targets LDH can inhibit oxalate overproduction in all pH types. The overproduced oxalate then travels to the kidneys, where it is normally filtered along with other waste and harmful products. When excess oxalate accumulates, it starts to bind with calcium, forming calcium oxalate crystals. These crystals may clump together to form kidney stones, also known as nephrolithiasis. The stones can cause obstructions in the kidneys, the urinary tract, and the bladder. Multiple surgical interventions, which can cause damage to the kidneys, may be required to remove stones. Calcium oxalate crystals can also cause nephrocalcinosis, or calcification of the kidney. Calcification causes kidney damage, infection, and inflammation, and reduces the kidney's filtering ability, leading to a decline in renal function. If untreated, this can lead to chronic kidney disease and eventually end-stage renal disease, which may require dialysis and a dual liver-kidney transplant. Systemic oxalosis will begin when glomerular filtration rate drops below 35 to 40 mils per minute. In systemic oxalosis, the excess calcium oxalate that cannot be filtered by the kidneys escapes and starts to deposit in the tissues of the skin, heart, eyes, and skeleton. Early diagnosis, along with aggressive supportive treatment, can reduce the formation of new kidney stones and slow the progression to end-stage renal disease and systemic oxalosis. There are ongoing efforts to develop treatments that, if approved, will address the overproduction of oxalate by hepatic LDH, which drives the progression of PH.
Applications in medicine. Kidney stones from early and most often causes symptoms during childhood or adolescence. Because of the very large amounts of oxalate produced, the kidneys of many people with primary hyperoxaluria fail by early to middle adulthood. But renal failure can occur as early in infancy, while others with primary hyperoxaluria reveals develop kidney failure. To date, experts have identified three different genetic causes of primary hyperoxaluria.
Primary hyperoxaluria. Why does it occur? Oxalate arises from a variety of dietary and endogenous sources and is considered an end product of human metabolism. Normally, only a small fraction of ingested oxalate is absorbed, ranging from 5 to 10%. Therefore, the majority of plasma oxalate is derived from endogenous hepatic production. Any oxalate that's absorbed from the diet or is endogenously produced is delivered to the kidney, where it is filtered and excreted as urinary oxalate. In enteric hyperoxaluria, there is increased colonic absorption due to GI abnormalities resulting in malabsorption. Malabsorption leads to increased delivery of fat to the colon, where it binds dietary calcium, and this decreases the ability of dietary calcium to bind to the oxalate in the gut, and increased soluble oxalate is then absorbed. In addition, bile salts and fatty acid increase intestinal permeability and further facilitate oxalate absorption into the blood. This leads to increase in plasma oxalate, which is excreted into the kidney, increasing urinary oxalate and increasing the risk of kidney stone formation. Primary hyperoxaluria results from increased hepatic production of oxalate, and we'll discuss that physiology next. This slide will delineate the pathophysiology of primary hyperoxaluria in the liver. On the left is a hepatocyte. The enzymes involved in primary hyperoxaluria are in red: AGXT, GRHPR, and HOGO1. Deficiency of AGXT, which converts glyoxylate to glycine, results in increased glyoxylate, which is converted by LDH to oxalate. This is primary hyperoxaluria type 1. In primary hyperoxaluria type 2, the enzyme involved is GRHPR. GRHPR encodes for glyoxylate reductase. Deficiency of GRHPR leads to accumulation of glyoxylate and hydroxypyruvate. Glyoxylase is converted to oxalate by LDH. Hydroxypyruvate is converted by LDH to L-glycerate. In primary hyperoxaluria type 3, the HOGO1 enzyme is involved in catalyzing cleavage of hydroxy-2-oxyglutarate into pyruvate and glyoxylate. Deficiency of this enzyme results in primary hyperoxaluria type 3, but the exact mechanism by which oxalate overproduction occurs in primary hyperoxaluria type 3 is not yet completely understood.